Hello, my name is Laurent Castera. I'm a professor of hepatology at the University of Paris and Beaujon Hospital in Clichy, France. Today, I'm going to discuss two recent studies addressing NAFLD severity in people with type 2 diabetes. As you're well aware, non-alcoholic fatty liver disease is becoming the most prevalent liver disease worldwide. This is the most recent meta-analysis based on 92 studies and almost 10 million subjects published by NAFLD and his team. And as you can see, the pool prevalence was around 30% for NAFLD, with prevalence as high as 44% in Latin America. In clinical practice, most of these people are seen in primary care and can be identified with risk factors such as age above 40 years, type 2 diabetes, obesity, and metabolic syndrome. And the challenge is to identify those with advanced fibrosis, F3, F4, that are the most at risk of developing liver outcome and mortality. Many pathways have been proposed recently using non-invasive tests to link patients from primary care to liver clinic, but efforts should be done also to link patients from diabetes clinic to liver clinic, because type 2 diabetes is one of the most important risk factors for NAFLD. This is another meta-analysis published 4 years ago by the Biopsies, 80 study, about 50,000 patients with type 2 diabetes. And you can see the prevalence of NAFLD is twice higher than in the general population, 55%. But interestingly, NAFLD seems to be more severe in type 2 diabetes patients. But look at the number of studies. It's much lower, 10 studies, less than 1,000 liver biopsy, and the prevalence of NASH was around 70%, and the prevalence of advanced fibrosis, 17%, but based only on 7 studies and less than 500 liver biopsy. And if you look at the confidence interval, there's a wide variability. So the limitations are that population-based epidemiological studies are weakened by the absence of liver histopathology. Studies based on liver histopathology are limited by small size, as I mentioned, spectrum biased. So we tend to biopsy the most severe patients, varied case definition, and most importantly, unclear indications for liver biopsy. Thus, the real prevalence of NASH and advanced fibrosis in patients with type 2 diabetes remains poorly known. Recently, 2 studies published in 2023 addressed the issue of NAFLD in type 2 diabetes patients. The first one on the left comes from the US, from the group of Roy Tlumba in San Diego, and addressed prevalence of NAFLD, advanced fibrosis, cirrhosis, and HCC in people with type 2 diabetes. The second on the right comes from France, the so-called Quid NASH project from 4 centers in Paris, and address prevalence of NASH and advanced fibrosis in type 2 diabetes. Their result can be summarized as follows. On the left, you can see that the prevalence of NAFLD in this American population was 65%, prevalence of advanced fibrosis 14%, and prevalence of cirrhosis 6%. On the right of the screen, prevalence based on liver biopsy was 58% for NASH, and 38% for advanced fibrosis and 10% for cirrhosis. So now let's dig more into detail in the study. In terms of design, the American study was a prospective single center study that was run from 2016 to 2022. The setting was liver clinic with referral from primary care and diabetes clinic, target population almost 500 patients, type 2 diabetes patients above 50 years old with suspected NAFLD. On the right of the screen, the French study was a prospective multicenter study run from October 2018 to March 2021, shorter duration. The setting was annual workup in tertiary diabetes clinic, and the hepatologists were seeing patients in the diabetes clinic. So out of 713 patients, 330 underwent liver biopsy. There was no age limit and all had confirmed NAFLD. The reference standard for the American study were both non-invasive tests and in a subgroup of patients' liver biopsy. So NAFLD was defined as MRI-PDFF above 5% or CAP above 288. Advanced fibrosis was based on liver stiffness measurement using MRI above 3.63 or transient elastography above 8.8 kilopascal. And as I mentioned, a subgroup of patients, 134, underwent liver biopsy with different indications, either elevated ALT with steatosis and liver stiffness around 7 kilopascal by transient elastography or MRE 265, or MRE above 330, or MRI-PDFF above 10%. On the other hand, the French study was only based on liver biopsy, 330 patients. And importantly, the indications were standardized based on pre-specified criteria. Low ALT threshold, 20 units in female and 30 units in male. Non-invasive tests were not taken into account to indicate liver biopsy. Absence of other cause of liver disease condition was central reading by a single pathologist, Pierre Bedossa, and transjugular route was used in case of morbid obesity and anticoagulant, and this was the case in around 1/3 of patients. Let's look at the characteristic of the population. They were quite different in terms of age older for the American, and more female, 63% against 37 in the French study. In terms of BMI, diabetes duration was pretty similar. You can see that A1C was lower in the American study, so were ALT. Platelet count, CAP, and liver stiffness were not that different. But now, if you look at the subgroup of patients with NAFLD, the characteristic apart from age and gender, pretty much similar in terms of BMI, treatment diabetes duration was shorter, and A1C was lower. Apart from that, was pretty similar. Now, we focus on the most interesting group, the population with advanced fibrosis, 69 patients in the US study, 124 in the French study. You can see that the characteristic apart from age and gender are very similar in terms of BMI, diabetes duration, A1C is again slightly lower, but otherwise, apart from liver stiffness, it's much more similar. So meaning that we're looking at different populations, but if we compare the same target, the characteristics are pretty similar. Interestingly, in the subgroup of patients with liver biopsy, you can see that the prevalence of NASH was also similar, 61% against 58%. Advanced fibrosis slightly lower, 30% as compared to 38%, and cirrhosis very close, 9% against 10%. What was the role of comorbidity? The most important one was obesity, and was significantly associated with an increased risk of advanced fibrosis in both studies, twice higher prevalence of advanced fibrosis in obese versus non-obese patients in the American study. And in the French study, you can see that waist circumference above 102 in male and 88 centimeters in female was in multivariate analysis an independent predictor of advanced fibrosis. Now, what about non-invasive test and model? These are the results from the French study. And you can see that if you're using FIB4 alone, so FIB4 is based on age, transaminase, and platelet count, the OROX was not that good, 0.71, and the percentage of correctly classified patients, true positive and true negative, was low, around less than 35%. Now, if you're using a model with different parameters, FIB4 plus waist circumference, GGT, and HDL cholesterol, you increase the number of correctly classified patients and the OROC, and this was significant. So this model did not use transient elastography because this technology is not available in most diabetes clinics and can be implemented tomorrow. If you're lucky and have transient elastography or better known as FibroScan available in your clinic, you can see that you significantly increase the OROX and also the percentage of correctly classified patients using it. If you're using the model combining FIB4, HDL cholesterol, and FibroScan, there was no significant difference in terms of correctly classified patients and OROC. So still, if you don't have a FibroScan in the diabetes clinic, you can screen for your patient on simple data and widely available and cheap. So the take-home messages are that patients with type 2 diabetes and NAFLD attending outpatient diabetes clinics have a high prevalence of advanced fibrosis and NASH despite mild liver test abnormality, which emphasize the relevance of choosing lower threshold for abnormal ALT level, namely 20 units in women and 30 units in men. And obviously, these high prevalence have been overlooked so far because of the lack of data and the low awareness regarding NAFLD in diabetes clinic. So patients above 50 years old and obese are at the highest risk of developing advanced fibrosis. As I've shown you, routinely available parameters enable many of these high-risk patients requiring further liver assessment to be identified and then linkage to care to be established with a liver specialist. So in conclusion, patients with type 2 diabetes should be systematically screened for liver fibrosis in diabetes clinic. Thank you very much for your attention.